Welcome to the Movement Assessments presentation. The purpose of this presentation is to provide the health and fitness professional with the necessary knowledge and observational skills to effectively assess human movement, creating the foundation for developing appropriate and effective corrective exercise strategies. Following this presentation, the health and fitness professional will be able to explain the rationale for performing movement assessments, understand the difference between transitional and dynamic movement assessments, determine potential muscle imbalances based upon certain movement compensations, and design a corrective exercise strategy to improve movement impairments. Movement is the means by which we are able to perform all activities, ranging from those necessary for daily living to our job tasks and recreational enjoyment. Our ability to move is one of the most important aspects of our existence. Understanding normal movement allows us to identify abnormal movement, which may be indicative of possible muscle imbalances for which we can then provide appropriate corrective strategies. Importance of a movement assessment. A movement assessment allows a health and fitness professional to observe human movement system impairments. The information learned from the movement assessment can be extremely useful to determine what muscles are underactive and overactive and how that impacts a client's ability to move properly. This information can then be correlated to subjective assessment findings, and collectively, this data will produce a more comprehensive representation of the client's functional status. Movement assessments can be categorized into two types: transitional assessments and dynamic assessments. Transitional movement assessments are assessments that involve movement without a change in one's base of support. This would include movements such as squatting, pressing, pushing, and balancing. Dynamic movement assessments are assessments that involve movement with a change in one's base of support. This would include movements such as walking and jumping. All movement assessments require observation of the kinetic chain, also known as the human movement system. To structure this observation, NASM has devised the use of kinetic chain checkpoints to allow the health and fitness professional to systematically view the body during motion. The kinetic chain checkpoints include the feet and ankles, knees, lumbopelvic hip complex, shoulders and cervical spine. Transitional Movement Assessment, Part 1. We will begin with transitional movement assessments. The two transitional assessments we will discuss in this presentation are the overhead squat assessment and the single leg squat assessment. Refer to your text for information regarding additional transitional assessments. We will start with the overhead squat assessment. The overhead squat assessment is a two-legged squat performed with the arms held overhead. This assessment was selected because it evaluates total body structural alignment, dynamic flexibility, and neuromuscular control from a bilateral standing posture. Squatting requires optimal motion in the ankles, knees, and hips. Furthermore, positioning the arms overhead stresses the musculature surrounding the shoulder complex and increases the demand placed upon the core stabilizing muscles, making this an excellent total body movement evaluation. The overhead squat assessment will be assessed from the anterior, lateral, and posterior views. To start, position your client with feet shoulder-width apart and pointing straight ahead. Have the client raise his or her arms overhead with elbows fully extended. The upper arm should bisect the ears. Next, instruct the client to squat to roughly the height of a chair and return to the start position. Have the client repeat the movement for 5 repetitions. From the anterior view, pay close attention to the client's feet and knees. The feet should remain straight, with the knees tracking in line with the foot over the second and third toes. Specifically look to see if the client's feet turn out and/or flatten, and if their knees move inward or outward. These movement impairments may be indicative of muscle imbalances in their lower extremities. When performing the assessment, record all of your findings and review the table in your textbook to view probable overactive or tight and underactive or weak muscles that may be contributing to these compensations. The probable overactive muscles will need to be stretched, while the probable underactive muscles will need to be strengthened. For example, during the overhead squat assessment, the knees should ideally remain in line with the second and third toes of the foot. However, a compensation that will commonly be seen is the knees moving inward toward each other, or excessively adducting, during the squatting motion. When this compensation is noted, one of the primary overactive muscle groups is the adductor complex. When these muscles are overactive, they will pull the femur into adduction during the descent of the squat. Additionally, the gluteus medius is implicated as underactive during this compensation. When underactive, the gluteus medius lacks the ability to eccentrically control the femur and counteract the pull of the adductor complex, thus allowing the knees to cave inward. This type of rationale was used to determine all overactive and underactive muscles for each of the movement impairments discussed throughout the presentation. From the lateral view, pay close attention to the lumbopelvic hip complex and shoulders. Like the anterior view, have the client repeat the movement for 5 repetitions. Specifically look for any arching or rounding of the low back or an excessive forward lean of the torso. At the shoulder, look for arms falling forward. Each of these compensations will indicate potential muscle imbalances at the lumbopelvic hip and shoulder complexes. And lastly, the health and fitness professional will observe the client from the posterior view. The client will again squat for at least 5 repetitions, while the health and fitness professional will be observing 2 main checkpoints, the feet and the lumbopelvic hip complex for specific compensations. At the feet, specifically look to see if the feet flatten or if the heels rise. At the lumbopelvic hip complex, look for any asymmetrical weight shifts during the descent of the squat. Each of these compensations will indicate potential muscle imbalances in the lower extremities and the lumbopelvic hip complex. As with the previous compensations, make sure to review the table in your textbook to view probable overactive and underactive muscles that may be contributing to these compensations. This will again provide you some guidance as to which muscles will need to be stretched and which muscles will need to be strengthened to improve movement quality. Transitional Movement Assessment, Part 2. There are a couple of modifications to the overhead squat assessment that the health and fitness professional can make in order to gain a clearer picture of the possible overactive and underactive muscles involved with specific movement compensations. These modifications include having the client squat with their heels elevated on a 2x4, a 10-pound weight, or a similar object, as well as having them squat with their hands on their hips as opposed to overhead. Elevating the heels decreases the stretch required during the squat from the gastrocnemius and soleus muscles. Essentially, this modification provides the client with artificial range of motion through the foot and ankle complex. Secondly, it alters the client's center of gravity forward. When the center of gravity is moved forward, it allows the client to sit more upright. In all, this modification allows the health and fitness professional to see the specific influence the foot and ankle complex has on a client's movement patterns. If a client exhibits a more ideal squat pattern with this particular modification, then it is likely the client's movement deviations are caused by a lack of ankle range of motion. Conversely, if the squat does not improve when the heels are elevated, this would suggest the lumbopelvic hip complex is potentially the primary dysfunctional region. This allows the health and fitness professional to really pinpoint what areas should be focused on during the corrective exercise program. Placing the hands on the hips directly removes the stretch placed on the latissimus dorsi, pectoralis major and minor, coracobrachialis, and requires less demand from the intrinsic core stabilizers. This allows the health and fitness professional to see the influence the upper body has on the client's compensations. Using the hands-on hips modification, we can use the same process of elimination. For example, if a client's movement compensations improve when he or she performs the squat with the hands on the hips, it can be suggested that the upper extremities have a major influence on the deviations seen. On the other hand, if the squat does not improve with the hands down, it can be assumed that the upper body has little effect on the deviations and has more to do with dysfunction of the lumbopelvic hip complex. The compensations may reveal tightness through the hip flexors and weak gluteals and core stabilizing muscles. The second transitional movement assessment is the single-leg squat assessment. This transitional movement assessment assesses dynamic flexibility, core strength, balance, and overall neuromuscular control. The client should place their hands on their waist. The feet should be pointing straight ahead, and the ankle, knee, and the lumbopelvic hip complex should be in a neutral position. To begin, have the client squat down on one leg to a comfortable height, performing up to 5 repetitions before switching sides. The health and fitness professional will be observing the knees, lumbopelvic hip complex, and upper body. The first compensation to look for is if the knee of the stance leg moves inward toward the inside of the big toe. Similar to the overhead squat assessment, make sure to review the table in your textbook to view probable overactive and underactive muscles that may be contributing to this compensation. This will again provide you some guidance as to which muscles will need to be stretched and which muscles will need to be strengthened to improve movement quality. The next two compensations can be identified at the lumbopelvic hip complex, characterized by the opposite hip hiking up or dropping down in the frontal plane relative to the stance leg. Ideally, during the single leg squat, the pelvis should remain level. The last area that will be evaluated during the single leg squat assessment is the upper body. Ideally, during the single leg squat, the trunk should remain in a neutral, forward-facing position with the sternum parallel to the stance leg. Two common upper body compensations are characterized by a rotation of the trunk. Trunk rotation toward the stance leg is considered inward trunk rotation, while trunk rotation away from the stance leg is considered outward trunk rotation. As with the previous compensations, make sure to review the table in your textbook to view probable overactive and underactive muscles that may be contributing to these compensations. This will again provide you some guidance as to which muscles will need to be stretched and which muscles will need to be strengthened during a client's corrective exercise program. Dynamic movement assessment. Dynamic movement assessments are assessments in which movement is occurring with a change in one's base of support. The dynamic movement assessments that will be covered in this lesson include gait analysis and the Davies test. The purpose of gait analysis is to assess one's dynamic posture during ambulation. To begin, have the individual walk on a treadmill at a comfortable pace at a 0-degree incline. From an anterior view, observe the feet and knees. The feet should remain straight with the knees in line with the toes. From a lateral view, observe the low back, shoulders, and head. The low back should maintain a neutral lordotic curve, and the shoulders and head should also be in neutral alignment. From a posterior view, observe the feet and lumbopelvic hip complex. The feet should remain straight, and the lumbopelvic hip complex should remain level. When performing the assessment, record all of your findings. You can then refer to the table in your text to determine potential overactive and underactive muscles that will need to be addressed through corrective flexibility and strengthening techniques to improve the individual's quality of movement, decreasing the risk for injury, and improving overall performance. A second example of a dynamic movement assessment designed to assess upper extremity agility and core stabilization is the Davies test. To start, begin by placing two pieces of tape on the floor 36 inches apart. Next, position the individual in a push-up position with one hand on each piece of tape. Instruct the individual to quickly move his or her right hand to touch the left hand. Perform alternating touching on each side for 15 seconds. Repeat for 3 trials. Record the number of lines touched by both hands. Reassess in the future to measure improvement of the number of touches and movement efficiency. While performing this assessment, also look for any overall deviations in posture. Some common postural deviations include an arching of the lower back or abdomen protruding down towards the ground, indicating weakness through the core musculature. Shoulders elevating, indicating weakness through the mid and lower trapezius and rotator cuff. And dropping of the head toward the floor, indicating weakness of the deep cervical flexors. Summary. In summary, transitional and dynamic movement assessments can be used to detect deviations in the functional anatomy of a client, as well as predict the probable overactive and underactive muscles that lead to human movement system impairments, which ultimately may cause injury. While they can be extremely useful, it is important to point out that movement assessments are only one component of a comprehensive assessment process and should be performed in conjunction with other assessments in order to confirm or refute the movement assessment findings. This will ensure the optimal corrective strategy is developed for the client, leading to a more effective program and greater results.